So hello, welcome to this short overview. It's an introduction to infertility. Uh, it's a short introduction, sort of like a teaser, because I want us to have a longer class on the same, but I wanted to introduce brief concepts that we can go through so that when we sit to the subject matter in subsequent lectures, we know the general overview. Um, the class, of course, is meant for KYU, year 4 students, and is tailored as the same. And to start off is to define what infertility is. And WHO states it as inability to conceive or achieve pregnancy after 12 months of regular and protected intercourse. And of course, the diagnosis can be made earlier if there are factors to confirm the same. Uh, Factors like age, factors like confirmed tubal blockage, and such. You are allowed to make a diagnosis earlier. You may hear the words infertility and subfertility being used interchangeably. And you may hear a distinction between primary and secondary infertility, where in primary infertility, one has never conceived, but in secondary infertility, they might have had at least one pregnancy prior to the onset of infertility. Said to affect at least 10 to 15% of couples globally, and is a huge burden socially and psychologically, and also economically. To understand infertility, of course, you need to understand normal reproductive biology. And you need to be very, very conversant with the HBO axis, ovulation, menstruation, and the role of the hormones and the levels. Of course, you need to understand for the male spermatogenesis and sperm transport, including anatomy of the male reproductive system. And what could cause? Like I said, this is a short lecture, a sort of overview lecture. So that's why I'm not going into much details, because we'll go into these details later. But in a brief or in an overview of what can cause infertility, the female factors account to up to half of the causes, and they can be ovulatory disorders like polycystic ovarian syndrome, hypothalamic dysfunction, or ovarian insufficiency. Tubal factors very common in our setup, either due to infections or endometriosis, but it can also be due to other causes of tubal occlusion like tubal surgery. Uterine factors like fibroids, common in our setup. Asherman syndrome, not common but seen once in a while. Cervical factors, a bit harder to diagnose, and stenosis might be caused by procedures done on the cervix. Male factors may account even up to 40% of the causes, either due to sperm production issues, transport issues, or issues that affect sexual intercourse like premature ejaculation or impotence. Then we have unexplained infertility, where despite all your investigations, you are unable to come up with a diagnosis. Now, risk factors will of course predispose you to those conditions we've talked about. Age is one, especially for women. smoking, alcohol intake, marijuana intake, obesity, and stress. These are things that either interfere with the hormones or can cause oxidative stress. Environmental toxins uh, like pesticides, radiation, amongst others. Illnesses like diabetes and thyroid disorders, and the occupational hazards I was talking about. Evaluation, the most important is history and physical exam, because that almost always guides you to the right investigation, so that you don't have to do too many investigations that may not be necessary. For the lady, if you are trying to find out if she's ovulating, the hormonal tests will be important. Of note is FSH, LH, prolactin and TSH, and anti-Mullerian hormone. Anti-Mullerian hormone will give you the ovarian reserve. Ovulation assessment, either by hormonal tests or by ultrasound or by uh, hormonal assays during ovulation. Imaging, very important. An ultrasound will give you a lot of information, but you can also do HSG to look at the tubes or sonohysterography to look at both. For the man, seminalisis almost always gives you a guide as to where you should look, and this will tell you whether you need to do further tests like hormonal tests, genetic testing, imaging as per indication. We'll look at this more when we are looking individually at female infertility and individually at male infertility. Now, your management options, of course, depend on the cause. And some of the measures that don't require a doctor include lifestyle modification, weight loss, you stop taking toxins, stress reduction, heat reduction for the male, amongst others. Medical management depends depending on the suitability of the patient, like ovulation induction or hormonal treatment for a male with low sperm count. Surgical treatments may include surgery to remove varicose veins in the male, to remove fibroids in the woman, to open the tubes, and so on and so forth. We'll look at them more specifically when we look at the specific causes. Then artificial reproductive techniques like intrauterine insemination, in vitro fertilization, and the various varieties of artificial reproductive techniques. Do not forget the psychological aspect, because these are couples or women or men who have undergone social stigma, who have also faced a lot of anxiety, they have spent a lot of money. So always remember the psychological aspect and the ethical and legal angle with some of these interventions we do to deal with infertility, like artificial reproductive techniques and surrogacy. So the takeaway I want you to have is that infertility has many causes, and you need to be very clear when you are doing your investigations on what you are looking for and whether you have the capability to handle what you are looking for. Make the right diagnosis, offer the right option. One common problem we face is finding somebody with tubal blockage being offered ovulation induction, and probably they have no issue with ovulation. So making the right diagnosis is key. Doing the right thing after doing the diagnosis is important, and always remember the psychological support. This is a case that is a Chemsha Bongo, just to give you a glimpse of the things to expect when you get into practice. Go through it. Uh, we'll discuss it when we are handling female infertility on its own. Thank you.